All right, Rachel, it's 8 o'clock.
All right, we'll get started. Welcome to part 4 of the COVID-19 and IDD webinar series. This is part of the virtual grand round. So my name is Rachel Backel, and I'm a first-year medical student at Geisinger Commonwealth School of Medicine, and I'm this year's American Academy of Developmental Medicine and Dentistry virtual grand rounds chair. For those that are new, virtual grand rounds are a webinar-based presentation model that creates a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the grand round sessions is to expand and strengthen the IDD workforce across a spectrum of experience levels. After this meeting, we will be sending out a survey for feedback on how to improve these meetings. So please see our Coronavirus Center on AADMD.org. It has a lot of good information about how coronavirus is affecting people who have IDD. And we will have 3 polling questions that you should see showing up on your left-hand panel in the bottom corner. And you might need to scroll a bit to see them all. And so this presentation is made possible through the support of University of the Pacific's Arthur A. Dugani School of Dentistry in San Francisco. I would like to introduce Dr. Alan Wong. He is our president-elect of AADMD and is a professor and director of the Advanced Education in General Dentistry Residency Program at Pacific Dugani School of Dentistry in San Francisco. He is also one of the 2 global clinical advisors for Special Olympics and will be introducing our featured speaker and special guest.
Thank you, Rachel. Very excited to have a wonderful speaker tonight. In this time of crises, it's great to learn about new skills and new techniques. We're going to have a great presentation tonight from Dr. Rick Rader. I'm very pleased to introduce that he is the director of the Habilitation Center at the Orange Grove Center in Chattanooga, where he is responsible for the creation, implementation, and evaluation of innovative and novel programs in healthcare delivery for people with intellectual and developmental disabilities. He is the editor-in-chief of the Exceptional Parent magazine and has published over 300 articles in this field. He is the vice president of public policy and advocacy at the American Academy of Developmental Medicine and Dentistry, and serves on the board of the American Association of Health and Disability. He is a member of the Medical Advisory Committee at Special Olympics International and is a medical advisor at the National Alliance for Direct Support in Professionals. Dr. Rader is a member of the steering committee at the National Task Group on Intellectual Disabilities and Dementia Practices. He's an adjunct professor of human development at the Chattanooga University, Tennessee, in Chattanooga. His experiences in advocacy is vast. He has helped mentor many professionals into successful advocacy projects. He's full of entertainment. He is full of wit and wisdom, and he's here with us tonight. I'd like to welcome Dr. Rick Rader, a great friend and great mentor. Dr. Rader. And Rachel, are you going to make Dr. Rader the presenter?
Yep, he already has the slides up.
Great. Dr. Rader, there you go. Thank you. While Dr. Rader's slides are setting up, if you have questions, we'll have a question and answer period at the very end. Dr. Rader has agreed to stay with us, but he has jam-packed full of information, so please stay tuned with us, but you can enter your questions in the questions and answer part in the section to the right of you. Thank you.
Alan, can you hear me?
Yes, we can, Rick.
Okay, great. Sorry for whatever the technicalities are. So I want to start by personally thanking Dr. Long, Courtney, Michelle, and Rachel for the opportunity to join me tonight. And I wanted to give a special shout out to the AADMD student chapters for their enthusiasm, their energy, and their contributions. It certainly gives us graybeards the joy to know that there are those of you who feel the work we started is worth continuing. So thank you all. Several of us actually think that the first A in AADMD stands for advocacy, as it was one of the first things we identified that we needed to pursue when we formed the Academy in 2002, following the Surgeon General's report. I originally created this presentation to prepare both medical students and residents to begin to appreciate their role, their obligation, and responsibility to advocate for their patients, families, and also to themselves. The pool of advocates that are needed in the IDD field extend way beyond the white coat. The need to advocate and become advocates has been recognized and adopted by our colleagues, and we welcome them. Social workers, policymakers, counselors, teachers, researchers, nurses, families, direct support professionals, the payers, the van drivers, the housekeepers, and the patients themselves are now all part of the needed legions of advocates. The need for advocacy grew out of a harsh reality that not everyone understands right from wrong, and for those who do see it, most of them prefer not to rock the boat. Advocacy can be intimidating, daunting, lonely, stressful, and overwhelming. But if you have the stomach for it, it can also provide you with the time of your life.
Dr. Rader, you're muted right now.
Are we back?
Yep, you're all good.
Okay, sorry. I wanted to start by sharing with you where I started. In 1993, over 23 years ago, I responded to a very seductive ad in JAMA, the Journal of the American Medical Association. Some center in, of all places, Chattanooga, Tennessee, was looking to initiate a program to help develop a specialty in developmental medicine. Of course, I knew nothing about that. In fact, no one really did. But the ad started with, quote, seeking an extraordinary professional, so who could resist? I kept the ad on my office wall to not only remind me how I got here, but what I'm supposed to be doing. I wanted to share this with you because of all the skills they sought, there was no mention of that of an advocate. And that was a good thing because that was not anything I was familiar with. But I wanted to share it with you to demonstrate that most of us who became advocates fell into it. It somehow got woven into our activities, somehow got to be as important as checking the boxes for preventative health screenings and training of medical and dental students. There were no electives in becoming a medical advocate. No pizza, lunch and learn meetings, no mentors, no programs, and certainly no board or exam questions. So however you got here, welcome. Can you hear me?
Yes.
Okay. So regardless of where the decision to become a physician is made, most set their sights on being a clinician, forming relationships with patients. After all, the clinician is the foundation of medical practice, the epicenter, ground zero for care. One of the great aspects of being a physician is the opportunity to explore and possibly assume new roles in medicine. Medicine offers lots of options, choices, and opportunities to make a contribution beyond the white coat. You can teach and reap the rewards of preparing future generations of clinicians. You can become a researcher, basic medical sciences, translational research, genomics, nanomedicine, stem cells, regenerative medicine. There are no limits. There's the pharmaceutical industry, research, drug and vaccine development, clinical trials, medical education, marketing, drug surveillance, emerging markets. The recent COVID-19 pandemic has made this area very attractive to many physicians. There's medical jurisprudence. As a physician lawyer, you can defend physicians or litigate against them. You can provide expert testimony, prevail over medical legal issues. You can help define standards of care. Again, COVID-19 has put careers in public health, epidemiology, and pandemics in the limelight. Opportunities with the CDC, U.S. Public Health Services, the NIH, Agency for Healthcare Research and Quality, the Institute of Medicine, and WHO can satisfy the medical detective need. You can combine medicine in the boardroom and become a physician executive, a hospital administrator, work for an HMO, accountable care organization, urgent care, health insurance company oversight, earn an MBA and become a medical entrepreneur. The AADMD Dr. Matt Holder is a great example of that opportunity. You can become a biomedical engineer and get involved with medical physics, artificial organs, brain-body interface, neuromodulation, predictive modeling, and longevity strategies. You can become a physician astronaut like Dr. Mae Jemison, the first African-American female astronaut. Have your office in the space lab doing bone cell research. You can also go into military medicine. What about being a physician politician like Tennessee's Dr. Bill Frist, noted heart transplant surgeon, U.S. Senator and Republican majority leader? He's a major influence in healthcare policy. As an aside, 11% of our founding fathers were physicians. You can become a medical ethicist. This is becoming increasingly more important with emerging technologies, increased longevity, resource allocation, and the blurring lines between can and can but why. Again, the COVID crisis shows the narrow margin between what's available and to whom. You can become a medical news correspondent. Neurosurgeon Dr. Morton J is reaching tens of millions of people with healthcare information, elevating the country's medical and health literacy. He turned down the nomination to be the Surgeon General and Senate staff. And last but certainly not least, you can become a medical humanitarian by joining one of several international medical relief groups, working in war-torn countries, fighting epidemics, and using medical care to influence social justice. Advocacy is about things that keep us up at night. I'm not talking about knocking off 3-hour zones before going to bed. One of the things that keeps us up at night have one thing in common. They typically revolve around hearing one or more of the following comments. You can't do that. You can't have that. Maybe once, but not anymore. You don't qualify. You're not eligible. That definition has been changed. You missed the deadline by a day. You obviously didn't understand what we told you before. That person no longer works there, so whatever they told you doesn't count now. That program is on hold. We've reached our cap. That clause is under review. You have to live on the reservation for that. We can't process your application without having your great-grandmother's maiden name. Changes in the healthcare system have in part forced us to wear the hat of advocates.
Dr. Rader, this is Ellen. We're getting a little fuzz on feedback. If you could just move your microphone out a little bit further and just a little bit louder, that'd be helpful.
Okay, how's that?
Better, thank you.
Okay.
And just a little slower. You got plenty of time.
Okay. Changes in the healthcare system have in part forced us to wear the hat of advocates. In the so-called golden age of medicine, before managed care, physicians prescribed, treated, and hospitalized their patients based on their needs, the judgment of the physician, and the availability of best and most promising treatment strategies. It is no longer true. Behold the chart of today's healthcare system. Try to find the patient. If you can't, the arrow is at the lower right part. Physicians spend hours on the phone justifying medications that are outside of these formularies, explaining why this case is different, and why this patient needs a different type of imaging, and why they need a referral to a regional specialty clinic. And while you may say that's just the way medicine is practiced today, it truly gave birth to the notion of the healthcare advocate. The so-called decision trees, algorithms, guidelines, and protocols have forced clinicians to exchange their stethoscopes for whiteboards and explain why one size doesn't fit all. In fact, often going beyond that and advocating for the idea that some of us can't wear ready-to-wear off-the-rack outfits. We need some customizing and tailoring. That, in essence, is the definition of an advocate. Someone who's there to ensure the best fit for the individual. And speaking of the best fit, it's us who have to find it. It's us who have to order it. We need to trade for it. We need to make it, or beg for it, or purchase it, and if necessary, grab it. What we can't do, what we won't do, is simply wish for it. Enter the medical advocate. If only it was as easy as you're in charge and swinging a saber. I selected the image of a cavalry charge not to suggest that that's what it's all about, but to call attention to the myth of the cavalry charge in medical equity. The truth is, no one is inviting you or encouraging you to lead the charge. The medical power brokers are content with the status quo. The other take-home about the cavalry charge is that it doesn't always work. Just ask General Custer at the Battle of Little Bighorn. Talk about announcing your intentions to the enemy. More often, medical advocacy is better suited for guerrilla warfare, small skirmishes that are not announced, hit and run, knowing the vulnerabilities of the opposing force and capitalizing on them. Most often, it is more effective to overwhelm your opponent with ongoing small victories. The big cavalry charge typically comes about in boardrooms, backroom offices, small hearing rooms, hallways, elevators, and in congressional hearings. So keep those ponies saddled, groomed, and nearby. Regardless of how you find yourself outfitted, in a three-piece suit, white coat, spacesuit, fatigue, or hazmat suit, there are abundant opportunities to become an advocate. It might look different, sound different, work different, but it's all about being an advocate and being there and there for our patients. It's evident more now than ever that physicians, without the heart of being an advocate, are simply technicians. While some of these case studies might appear almost trivial and low level, trust me, to the individuals they impacted on, they were big time. But for a first outing, you should look for low level injustices. They're a great training ground. You don't want to pitch your first game in the major league, so practice your pitches in the minor leagues. I assure you that there will be scouts looking out for new talent. Hitting a home run feels great, even if it's for the El Paso Chihuahuas or the Toledo Mudhens. And when I say practice your pitch, I literally mean it. Your pitch is your story and your solution, and you have 5 minutes to deliver it. In that time, you have to identify the problem, say why it matters, and to whom. The potential solution needs to be provided, and who are you, and how can you help? It's like speed dating on steroids. It's called the elevator speech, because at best, that might be the place to give it, and the time it takes to go from the ground floor to whatever floor the rainmaker is going. You come across this person by literally stalking them, let's just call it close pursuit, ambushing them, or casually running into them, which never happens. At best, after a 15-second preliminary pitch, they will say to you, walk with me or ride with me. Don't count on more than 5 minutes. The best scenario is that they will turn to one of their staffers and say, get me more information about this. It could be blowing you off, or it could be genuine interest. Treat it as if it's the latter, and have something to leave behind, a single-page summary and where they can contact you. This is called a home run. So what exactly is advocacy? In actuality, it's a problem-solving technique. It typically represents the haves and the have-nots, the ins and the outs. It's very much about the seat of power, who occupies it, and what they gain out of running the show. If you understand the authority gradient, you will understand advocacy. It's also about salesmanship, convincing someone to buy something that they personally won't benefit from beyond the benefit of doing the right thing. Margaret Mead, the anthropologist, said, never doubt that a small group of thoughtful people could change the world. Indeed, it's the only thing that ever has. Advocacy comes in several flavors. We have system advocacy, changing the system, promoting causes. Legal advocacy, what lawyers are paid to do. Legislative advocacy, designed to change laws. Individual advocacy, advocating for another. And self-advocacy, advocating for oneself. Let's look at some case studies demonstrating how advocacy can actually change things. First case is an example of individual advocacy, where a single person is in your crosshairs, but representative of a larger population. Meet Amelia. In 2012, she was a 3-year-old girl with Wolff-Hirschhorn syndrome, a rare chromosomal condition involving the deletion of the distal short arm of chromosome 4. She needed a kidney transplant. So her parents go to CHOP, the Children's Hospital of Philadelphia, one of the country's most respected pediatric transplant centers. Picture this. Amelia is across the table from the transplant surgeon, bouncing on her mother's lap, when the transplant surgeon declares, we don't waste organs on kids like that. You can imagine the outrage, humiliation, and rage. It was a perfect case for the AADMD to get behind. We immediately began a nationwide letter writing campaign. For one thing, there was no request to put Amelia on the transplant list. The mother was a suitable and willing donor. I became a little guerrilla fighter. I wrote personal letters to the spouses of every member of the hospital's board of directors saying, when the spouse comes home tonight, be sure and ask them why his hospital is denying an organ to a dying girl. Well, we're not sure what exactly did the trick. CHOP recanted, apologized, and performed the surgery, and Amelia did fine. This advocacy resulted in several states passing laws prohibiting receiving organ transplants to people with intellectual disabilities, even though the American with Disabilities Act covered that in their discrimination policy. Chalk one up to the good guys. Mrs. Rivera personally thanked the AADMD at their annual meeting for our advocacy efforts. It was among our finest hour. Next is the case for overturning the ban on hot dogs. In 2000, the state of Tennessee banned hot dogs for individuals receiving state funds for support. They claimed hot dogs caused choking, and of course they were right, but only in certain cases and in certain conditions involving behaviors, dysphagia, and lack of supervision. The overwhelming majority of individuals with IDD were fully capable of having a hot dog. Their decision was based on one incident in which the individual took a discarded hot dog from a garbage can and ate it. He was unsupervised despite his individual support plan, and while it was tragic, it should not have been the impetus for a global ban. This outraged me, as it was an example of a slippery slope back to institutional prohibitions and not based on individual histories, preferences, and choices. Besides, the state was using 30-year-old statistics for individuals under the age of 8 for a 3-year period and without averaging. My research revealed that most choking in this category was due to latex balloons and candy, peanut scrapes, and popcorn, and they accounted for more choking incidents and deaths than from hot dogs. The other foods, however, were not banned. And while you can't blame their overprotective directive, it was truly a knee-jerk reaction, and it needed some additional study. Instead of banning all hot dogs, I proposed that only individuals with a history of previous choking incidents should not have access to the hot dogs, that we should institute an advanced training program for direct support professionals to better identify early signs of dysphagia, referring those at risk to swallowing therapy, have access to hot dogs that have been appropriately modified for textures, etc. In essence, a program that was person-centered, not hot dog-centered. I contacted the National Hot Dog and Sausage Council. Yes, there really is such a group. It's a trade organization. And I got access to their entire legal staff pro bono. They were waiting in the wings to initiate a class action lawsuit against the state. While a lawsuit is tempting, you might think, I'll teach them not to mess with me. At best, it's a last resort. It's costly even if it's pro bono. It takes forever. You burn bridges. There's little upside and no guarantee of the outcome, and often loses perspective. Don't rely on it. We prevailed, and that following July 4th, thousands of individuals with intellectual disabilities safely enjoyed hot dogs at the picnics held across the state. There was no choking incident. Yes.
I'm so sorry. You're sounding a little muffled again. You were good at a moment ago, so if you can just a little slower.
Is this better?
Yes, sir.
Okay.
Thank you.
Okay, so we prevailed, and following July 4th, thousands of individuals with intellectual disabilities safely enjoyed hot dogs at the picnics held across the state. There were no choking incidents, except the Vice President of Human Resources at a state developmental center had to be Heimlich. I love this next one. I call it the state's attempt to block the sunburn saga. Folks with or without disabilities are prone to sunburn if they are left out in the sun. And the simple solution is to apply sunblock to those exposed areas. Sunblock makes sense. It's easily obtained, over the counter, inexpensive, reliable, evidence-based, portable, easily and safely applied. Word got to me that the state of Tennessee, and this could have been any state, had ruled that only nurses or staff certified in medication administration could apply sunblock to individuals with IDD. This, of course, was nuts, totally insensible, and without merit, facts or without evidence of harm. So if you wanted to go to a ball game, a nurse had to be there to reapply the sunblock. The expense of having to hire a nurse for 1 or 2 individuals often made the outing economically unfeasible. So I called the Department of Intellectual and Developmental Disabilities and spoke to their medical director, a personal friend of mine, highly respected advocate and knowledgeable physician. In my mind, I thought this was going to be a slam dunk fix. Instead, it was a brutal lesson that people who become bureaucrats act like bureaucrats. I imagine if the agency that pays you to toe the line, that's what you do. If you sign on as a bureaucrat, it's bureaucracy that leads the way. And that's what happened. The physician told me that, quote, I didn't fully understand the politics behind this, that it was too complex, and it involved the nursing board, which they wanted to regain control of their influence. Then it involved the pharmacy board, who were forced to declare that sunblock was a medication based on the federal definition that it prevented disease such as sun poisoning and skin cancer, and also the state medical board, who ruled against lay people dispensing medications. So it became a triple whammy. I was pitted against the nursing board, the pharmacy board, and the medical board, not to mention the State Department of IDD. The behind-the-scenes tactics will not be revealed. Suffice it to say that I cautioned the state of Tennessee that they were forcing our direct support professionals to opt for one out of three choices, none of which were attractive. One, apply the sunblock and face termination, possible assault charges in violation of the medical board. And two, send the folks out in the sun without sunblock and face charges of neglect, mistreatment, and endangerment. Or three, and what I consider the worst, don't apply it and don't allow them to go outside. This was a violation of several severe civil rights legal actions. I'm glad to report that the department's medical director became my ally and was able to overturn this ludicrous rule. My folks went outside. They went fishing, boating, jogging. They went to ball games. They flew kites. They went on picnics and nature walks, all with an abundance of sunblock, and none of them became sunburned. So the lesson is, be prepared for lunacy, be prepared for irrationality, and be prepared to share your intentions, your facts, your experience, and of course, the consequence if they do not act accordingly. The consequences for the state was being turned into the Office of Civil Rights for violation of the Olmstead Act, so it pays to know the law. While many advocate projects require us to deal with laws, there is a host of non-laws that also serve to be impediments to achieving the goals of our projects. In fact, most of our assignments in advocacy begin when one or more of the following come into play and are thrown at you. If any of you can figure out what exactly defines some of these terms, please let me know. Sooner or later, you will be told that it's because of this that is prohibiting you from getting what you think is appropriate. So now we have the law, the rules, the regulations, the guidelines, the provisions, the protocols, the mandates, the bills, the clauses, the codes, the decrees, the edicts, the commitment, the understanding, the statutes, and of course, the requirements. When there was a medical emergency involving a resident in one of our group homes and we called 911, it was always reassuring to see the ambulance and the paramedics arrive. Unfortunately, EMS, the Emergency Medical Services, decided that our direct support professionals would not be permitted to ride in the ambulance to the hospital. The new ruling dictated that only family members could ride in the ambulance. We were told it was part of the regulations. If you think it's challenging to overturn a law, try overturning a regulation that no one could actually find, locate, cite, or pinpoint. It's a repeating theme for advocates. And while an unfounded regulation has no real authority, no authenticity, or no means to be enforced, try arguing that with an EMT or paramedic as they are loading one of your residents into the ambulance. As they drove away, we typically heard them say, "It's the rule, a stupid rule, but it's what we were told." Of course it was a stupid rule. For the majority of our individuals, their direct support professionals were indeed their family. They knew them, understood them, could interpret their nonverbal communication. They could share previous visits to the emergency room and give advice like, don't put the siren or flashing lights on. If he crosses his legs on the stretcher, don't make him uncross his legs. If he needs an IV, only use the left arm. The paramedics needed this guidance. They profited from it and understood that it often made the difference between a successful ER visit and one with potential disaster. There's a tried and true rule in advocacy. Tell your story. People are people, and they can relate to people's stories. Quite frankly, the public doesn't give a hoot about the plight of 5,000 Shetland ponies dying as a result of new regulations not permitting families to adopt them in the wild. What they do care about is one girl and what it meant to her to be able to adopt the Shetland pony, care for it, ride it, train it, and make a commitment to become a veterinarian. It's the story, the narrative, and why it matters to the people telling the story. My strategy was not to tell the story of what it means to our individuals to have their support staff accompany them in the ambulance. My strategy was to have the EMTs and the paramedics tell their story, what it meant to them to have an added complement of reliable information, how the DSPs had redirected their approach and behavior to the highly confused and frightened man with Down syndrome who was spitting up blood, how suggestions were offered that ran contrary to their typical protocols and training, and time after time it made a difference. Oh, one thing I forgot to tell you about the story and the impact of the story. The story is certainly part of the advocacy equation. The other part is who needs to hear that story. I arranged to have the EMTs tell their stories at statewide meetings of the Paramedics Association. We created EMT panels to tell their stories, tell them in front of the EMT chiefs, policymakers, the commanders, the medical advisors, the training officers, and most certainly the risk management officials. Now, when there is a medical emergency involving a resident at one of our group homes and we call 911, it's again reassuring to see the ambulance and the paramedics arrive and drive away with both the patient and the direct support professional. And while that's a brief summary, the devil was in the details, proposing behavior, expectations, and roles. And it did take a year and a half, but chalk up another one for the good guys. In addition, we know of 3 other states that had enacted the same regulation using our policy to set things straight in their states. In the 1960s, Dr. Robert Guthrie created the first newborn screening test. He was able to test for PKU, an amino acid disorder called phenylketonuria. If detected early enough, it was manageable by dietary adjustment. Over time, other tests for other inborn errors in metabolism were developed and made part of the screening regimen. Laws were passed that required all states to test newborns for PKU, congenital hypothyroidism, and galactosemia. Countless babies were saved from a lifetime of incurable disorders. While the screening of these 3 disorders was significant, when I moved to Tennessee in 1994, I was aware that there were many more types of disorders that could be tested and treated. Unfortunately, they weren't in Tennessee. So how do you get from this collection of 5 small blood drops to this list of almost 80 disorders? I knew the answer, and it was simple. You purchased this, tandem mass spectrometry, the equipment that could make these tests possible. You needed this to clinch the deal, about $1 million. I started to campaign for the Department of Health to purchase the equipment, and much to my surprise, I hit roadblocks after roadblocks, many from the medical community and the Department of Health. It was obvious that they were skeptical, reluctant, and threatened. They could not understand why I, this physician in Chattanooga, the physician involved in the support of people with disabilities, was interested in preventing disabilities. It seemed to them to be counterintuitive. They even investigated me to see if I had a financial stake in PerkinElmer, the company that manufactured the tandem mass spectrometry, thinking I was advocating to line my own pocket. When I decided to bypass the genetics community and start to work on formulating a state law, the genetics community didn't know what to do with me. Thinking that they could keep a closer eye on me, they foolishly appointed me to the State Genetics Advisory Board. At the end, I have no doubt that it wasn't necessarily the ethical and humanistic pleas that I made, but the cost savings I was able to demonstrate to the state Senate. The cost of providing care for a child with a complex disability across the lifespan was approaching over $7 million. And of course, the stories that brought families to Senate hearings, families who brought their charming, delightful young children, children who through basic universal newborn screening were safe from these inborn errors and time bombs. I made the argument that if so many children were safe from 3 disorders, what about the children who could be safe from 80 of these diabolical culprits? The Senate passed the law which required babies born in Tennessee to be screened by the complete battery of newborn screening. There's nothing in politics that rings truer than the expression, 2 things you don't want to see being made, the law and sausages. They cut the check. Every month I receive printouts of all the babies that were detected and saved by Tennessee's expanded universal newborn screening. The year after the law was passed, the Genetics Advisory Board asked me to help them add cystic fibrosis to the list of newborn screening. I got it passed at a cost of 2 phone calls. And if you're looking for an advocacy project, here's one for you. Despite the fact that we now have the technology and know-how to test for 80 of these life-saving changing disorders, it is up to each individual state to decide how many screenings they want to provide. I call it disability by zip code. Depending on which state you live in, Your child could either be saved from a lifelong disability or made to endure it. It makes no sense that there is no federal legislation that requires all states to provide the ultimate number of newborn screenings. But don't get me started. If you're going to route of getting a law passed, it's far better to have the castle lower the drawbridge for you than to have them stock that moat with hungry alligators. You should know the decision making, what motivates them. Get behind them, find out if there's any relevance to the disability field. Stay informed. The landscape is a moving target, and while you're basically trying to advocate for something, some law might come in to just totally derail that. Stay connected. The legislative staff is the young, pimply faced college graduates working 110 hours a week. They're often very reassigned. Use every opportunity to learn and share information about the cause. Anticipate questions and make sure you have the answers for them. But having a law passed to support your advocacy efforts is a special kind of sweet that only several of us have ever experienced. Over 10 years ago, we found ourselves in the throes of another pandemic. In 2009, we were confronted with the H1N1 flu pandemic, also known as the swine flu. It came to my attention that the CDC, predicting that they may not have ample supplies of the vaccine, had prepared a list of high-risk populations, people that they felt should be on the list to receive the vaccine. While children with intellectual and developmental disabilities were put on that list, adults with IDD were dropped from the list. By 2009, I knew my way around the CDC pretty well. I served on several committees, task force, advisory boards, and had key people on speed dial. This time, the advocacy strategy was conducted behind closed doors. No fanfare, no protests, no threats, and no exposure. Quiet and civil. The CDC released an updated list of priority populations earmarked to receive the swine flu vaccine. No apologies, no explanations, no retractions. Simply an updated list listing adults with ID. It was done quickly, requiring only a few phone calls to the right people. And while you could say that was too easy, it was the result of being in the trenches for over 20 years, earning a reputation for being earnest, persistent, and unwavering. So sometimes you can actually feel like the cavalry, and I urge you to celebrate those times. If you think of advocacy as a sport, mostly a team sport, you know that eventually you get outscored. So while we have demonstrated several successful case studies of advocacy, we know all too often that we learn more from our failures. I first learned about landmines as a rural medical officer in Mozambique in the 1980s. I learned about them in the most vivid and unforgettable way imaginable. In the early 1990s, several non-governmental organizations collaborated to form the campaign to ban landmines. In 1997, the group was awarded the Nobel Peace Prize. In 1997, the Ottawa Treaty was established to prohibit the use, stockpiling, production, and transfer of anti-personnel mines. To date, 160 countries have signed on to support the treaty. On December 2nd, 2009, Rwanda was declared free of landmines. 9,000 mines were removed by 180 Rwanda soldiers over a 3-year period. Our failure. The United States is the only NATO member who repeatedly refuses to sign and ratify the treaty, along with Russia and China. Hundreds of thousands of landmines remain buried, waiting for someone to find them, or worse. One of the AADMD's advocacy programs is the long-standing push to have people with intellectual and developmental disabilities recognized as being medically underserved, or MUP. We now have the Healthcare Extension and Accessibility for Developmentally Disabled and Underserved Population Act, which we call the Heads Up Act. We have been working on this for over 15 years. This federal designation, which would assist in increasing access to competent care for people with intellectual disabilities, has had several instances of positive momentum. We have had support from many members of Congress, but as we are all too familiar with the changing climate of the political landscape, there have been several instances where the momentum found itself without the needed stream. We have received the support, endorsement, and commitment from the country's most influential and respected disability rights organizations, who are currently on the sideline but preparing to regroup and reconsider our game plan. The political dancing, deal-making, and changing priorities are the stuff for Netflix, so stay tuned. This next case, which had its origins from COVID-19 pandemic, is an example of how often we are invisible. I say invisible because many of the oversights or blanket regulations that impact on our population are not intended to hurt us, but because we are invisible, these regulations often put us in precarious and challenging situations. Hence the expression, if you're not at the table, you're on the menu. The ruling that prohibited all visitors from being with hospitalized patients has epidemiological merit, but in terms of patients with intellectual and developmental disability, hospitalization has as many risks as the conditions that placed them there in the first place. Our individuals need a friendly, knowledgeable, and comforting support to help ease their anxiety, explain what's going on, and to act as both an advocate and interface for the healthcare professionals that rely on the DSP to provide accurate, reliable, and consistent information relating to the individual, their condition, and their past experience. So the AADMD sounded the alarm, and in a very short time, we created a position paper, lined up a national group of supporters, and in fact influenced several states to amend acts to allow hospitalized patients with intellectual and developmental disabilities to have authorized visitors. Dr. Seth Keller made a significant contribution to this initiative. Other states are still processing the proposal, and many hospitals have independently made the provision to allow DSPs at the bedside. Another example of our need to be advocating for our individuals during a crisis. It's important to recognize that advocacy has a timeline, and the effective advocate will understand and appreciate how that impacts on their crusade. Some of the AADMD advocacy efforts are still ongoing and have already been active for over a decade, and some of our efforts have been only a couple of weeks old and are able to turn on a dime. Of course, the strategies, the tactics, and the energies are different for the acute advocacy projects as compared to the chronic ones. In the early days of watching the COVID-19 pandemic reach apocalyptic productions, we got word that several state health departments had prepared a list of selected populations that would not be eligible to be placed on the list for access to the expected shortage of ventilators. None of us were surprised to see that individuals with IDD were on that list. It was an additional reminder that when things are going well, everyone loves to watch the young Special Olympics athletes race across the finishing line. But when it comes to limited resources, they are quick to draw a line in the sand and to announce and question, why would we give that last ventilator to one of them? Again, the AADMD advocacy machinery sprang into action. With lightning speed, we created both a policy and a position statement and an action plan. Following our strategy of collaboration, we quickly aligned an impressive list of partnerships. The fact that most AADMD activists now carry a copy of the Americans with Disabilities Act has become a significant tool in our armamentarium. Our phone number is becoming familiar at the Office of Civil Rights. This discriminatory practice of naming large populations as being unworthy of receiving optimal medical care was quickly derailed. Another successful cavalry charge. Dr. Matt Holder crafted this policy paper for the AADMD, and it's sheer poetry. Here is some inside trading information. Consider yourself a disruptive innovator. It sounds sexier than an advocate. When it comes to connecting, collaborating, and coercing your opponent, here's some advice to winning them over. Always give them an out, a chance to make whatever you need to happen. Give them credit. It costs you nothing. Give them a photo op. Thank them in reports, interviews, and announcements. Give them the chance to appear as innovators, progressives, and humanitarians. At each turn, send a handwritten note of appreciation. No one does that. It gets noticed. Be sure and send notes to the congressional staffers. You never know where they will wind up. They often get anything signed they put down on the desk of the decision makers. Find out as much personal information as you can on the people you are dealing with. Again, see if there's any personal connection that can be referenced in your relationship. Always remember there has to be a certain amount of give and take. All parties have to walk away thinking it was a win-win. There is no room for feeling like you lost. Sometimes it requires some star salesmanship to convince them that indeed they did win. There is an art and science to advocacy. Both will come to you in time. Here is the secret to being a successful advocate. I compare it to peeing in your pants wearing a dark suit. You will get a warm feeling, but no one else will notice. At the end of the day, there needs to be a little bit of pirate in all of us. But don't worry, the AADMD has enough eye patches to go around. While it might be customary to dedicate this presentation to all those advocates who have come before us and taught us how to play the game, it's obvious, well, we don't do customary around here. So instead, I would like to dedicate this presentation to the memory of Chief, the last active U.S. cavalry horse. Thank you for your service, and thank you for attending tonight's lecture.
Thank you so much, Dr. Rader. I really appreciated the presentation. We actually don't have any questions right now, but we do have a comment that everyone has been loving these tips, and they'd like a handout, actually, of the list of the advocacy.
Yeah, thank you, Dr. Rader, for that. In terms of advocacy, right now, what are your recommendations to people who get involved in advocacy? Do they contact someone, or what are your thoughts?
Well, for one thing, we do have a committee on advocacy at the Academy. And for any student members or any members of the AADMD that would like to serve on the committee, they can contact me, and we can basically share with them what's in our portfolio, and basically give them assignments either to research, identify the key players, identify the resistance, and the history of that. That's one of the key features in being an advocate. You have to know what you're getting into. You have to know why the policies, whether or not they are financial, or whether or not they are testimonial, or whether or not they just go against the concept. For instance, one of the reasons that the United States has not been a signer of the International Convention to ban landmines is they don't sign international conventions that put them at ill at ease. And so you really have to overcome basically a thematic part of the government very, very often. So yeah, that's the way to start being an advocate, and to pick your fights and make sure they're within your level.
Thank you. I know we have a lot of guests from all over. Recognizing a lot of names from locally here in San Francisco, our UOP faculty, our residents. I see some of our global scholars and many of our Special Olympic volunteers, global clinical advisors, some of our regional clinical advisors, Dr. Kumar in India and Dr. Abbas in Abu Dhabi, and Dr. Friedman over there in Canada. We have lots of other organization friends, the IADH, the International Association of Disability and Oral Health. They're wonderful advocates as well. We have Dr. Alison Dougal there in Ireland, and Dr. Sheila Thompson in the UK. We're blessed with a lot of other volunteers. We have Maggie Haney over there in Egypt, and we have our friends at AAIDD, the American Association of Intellectual and Developmental Disability, all partnering and all doing great things together. So I think advocacy is part of everything, and as we collaborate, I think we can advocate more. So I'm encouraged by all these. I'm encouraged by the young folks at the AADMD Student Resident Group. I've never seen a more active body of young professionals trying to do the right thing. So thank you for being a champion advocacy, Rick. You really sort of lead the way.
My pleasure. You know, I compare advocacy to ethics. You know, when ethics was started to be introduced to medical school curriculums, it was usually thrown into a Friday afternoon lunch and learn. And basically what that gave was the message that this isn't terribly important. Ethics, of course, should be taught at every case, every bedside, every morbidity and mortality lecture, etc. And hopefully advocacy will become that too. You know, right now, at best, it's a Friday afternoon lunch and learn, but basically it should be part of the curriculum. It's just as important to understand anatomy as it is to understand the anatomy of getting things done that are in the patient's best interest. And that's not done by a lecture. That's done by practicality. That's based on being side by side with right-thinking colleagues and seeing the results.
Yeah. I was going to say I totally agree, but we have a few more questions actually that came in. If you're willing to answer them.
Sure.
Has there been any ethical issues with clinical trials for COVID drugs and use for individuals with IDD?
Well, yeah, there's always ethical concerns about using individuals with intellectual and developmental disabilities in any clinical trials. And that's a shame. You know, there are three populations that drug trials are typically not used on: pregnant women, children, and folks with intellectual and developmental disabilities. The problem with that, with excluding our population from participating in drug trials, is by the time these drugs come to market, we are basically prescribing in the dark because we don't know what the unique peculiarities are of these drugs on our individuals. So we can't always rely on understanding the dosage or the clearance or basically the periodicity of the drugs. Very, very often the side effects and the drug-drug interactions will be quite different in our population. So, yeah.
Great, and we have a few more questions. Before you answer them, could you possibly make that presenter so I can display a few slides?
What do you want to do?
Could you make me the presenter by, if you scroll over my name, there should be a little chat box that says like make presenter.
Okay.
I think I'll go ahead and do that for you there.
Okay, thank you.
There you go.
So, so one person has a question on advocacy and face masks being required for people with IDD to wear them in the doctor's office, but when they are unable to wear them, they are being turned away. How do we manage that?
Wow, that's a good question. I'm not sure that actually falls under the auspices of advocacy or basically just clinical appropriateness. You know, certainly I understand the CDC guidelines, and basically I myself went to a physician's office today and everybody was wearing a mask. I think a lot of that has to do with our abilities or our inabilities to explain to our individuals why these masks are important. And certainly if the first time they're exposed to a mask is on the way to the doctor, that's shame on us. We need to employ positive behavioral techniques and basically, you know, start by basically showing them what it feels like to put their hand over their mouth and basically why it's important. One of the difficulties that we're seeing in terms of behavior is our inability to explain to individuals with IDD why they're being quarantined, why basically they're being curtailed from human touch and human contact. There's probably no other group other than our individuals that enjoy high-fiving, that enjoy basically hugging each other and shaking hands. And so on one Monday morning, all of a sudden, the direct support professionals come in and just say, by the way, there'll be none of that. Without the proper explanation, you know, it basically just seems very, very punitive. And so I basically would call in some counselors, or if an agency is lucky enough to have a behavioral analyst, what is it that basically is bothering that person, and what basically are the, why do they feel like it's infringing on them? There are other ways of doing it. It might be to decorate the mask. It might be for them to understand it better. But yeah, most of the problems that we have with COVID therapeutics and personal distancing is simply because of our inability to explain what's going on. Our folks may not understand it, but basically they are very intuitive and they know when their world is being disrupted. The problem is not giving them a context of why we are disrupting them, and also to reassure them that one day things will go back to normal.
Thank you, Dr. Rader. Thank you, Rachel, and thank you for bringing up the slide. We have a virtual conference for AADMD coming up June 5th to 7th. For dental students, medical students, it's complimentary, it's free, and something to look at. And we have special rates for those who want to join us. Please take a look at our website at aadmd.org for our virtual conference. We've got some great speakers. We got some wonderful collaboration. We will be having one panel on Saturday with AIDD and AADMD on a spectrum discussion on autism. So thank you everyone for attending. Rachel, do you have a final word?
Yeah, I just wanted to thank Dr. Rader for presenting. And I also wanted to mention our part 5 of the COVID-19 IDD webinar series, which will be June 3rd at 8 p.m. We'll have Meng Zhao Mei speaking about her experience in Wuhan.
Fantastic. Thank you again for helping us put this all together. Attendees, thank you again for being with us. Sorry about the little sound, little problem at the beginning, but we appreciate you being with us. Have a great night and stay safe.